rural onboarding happens during February and March, and then we have a monthly webinar that will be taking place from now until November. And we are very pleased to welcome Dr. Cascia Day to this evening session, where she's going to be talking to us about chronic urticaria, which is actually a topic that I don't think I've ever heard covered in one of these many series of webinars that are going around at the moment. So there's always these areas that are actually quite common and very much neglected. So Dr. Cascia Day is one of 2 registered physician allergists in South Africa and is currently completing a PhD on ACE inhibitor, angioedema, biomarkers, and genetics in Africa, with funding support from Discovery, as well as the SAMRC Bongani Mayosi Research Capacity Development Fund. Cascia completed her undergraduate degree at Wits in 2010 with distinction, and she completed her internship at Tygerberg and a ComServe year at Khayelitsha District Hospital. She underwent further training as a specialist physician at UCT, where she graduated in 2020. And then she has sub-specialised in Allergology and Clinical Immunology and graduated in 2023. So Cascia is a member of the steering committee for the International Network of Antibiotic Allergy Nations and a focus on penicillin allergy delabeling in Africa. And she's been the co-chair of the UCT Department of Medicine Research Symposium Committee since 2023. She's a clinician scientist with experience in both original research and industry trials at the UCT Lung Institute Allergy and Immunology Unit, with a special interest in drug allergy, infectious disease, angioedema, and urticaria. Cascia is passionate about allergy education and improving access to care in Africa, and we are very excited to have you here today. Thanks very much, Cascia. I'm going to hand over to you.
Hi, thank you so much for the very kind introduction. I'm just going to put my screen on so everyone can say hi and know that you're not talking to a robot or AI. And I'm going to now just share my presentation. Great. So I hope everyone can see the presentation. Tonight, we're going to be discussing chronic urticaria, and I just want to say thank you so much to Rudasa and the RAMP program for inviting me to come and talk about this topic. I work at Urticaria Hospital as well as the UCT Allergy and Immunology unit at the Lung Institute. And I'm very proud to say that our unit is a Galen Network UK centre, which means that we are an urticaria centre of excellence and reference. So we are the only urticaria excellence centre in Africa. And if anybody has patients they would like to discuss or any concerns or anything you'd like to contact us about after this talk, please feel free. So why is chronic urticaria a problem? Well, chronic urticaria is a very, very, very common condition and is not often spoken about, but is often seen in clinical practice and unfortunately is managed very, very poorly. So today we're going to be looking at a couple of things. Before we can discuss chronic urticaria, we have to define what urticaria is and briefly look at acute urticaria. We'll then look at the chronic urticaria and the different subtypes that you will see in practice, the current management guidelines, some very recent hot-off-the-press data from our South African research centres, and then some barriers to care as well. So what is urticaria? Urticaria is defined as an itchy, raised red or skin-coloured welts that blanch or turn pale when pressed. And something that most of you don't know is that everybody's lifetime prevalence or lifetime risk of urticaria is 20%. So that means that 20% during your life, you have a 20% risk of developing urticaria, whether that is acute or chronic urticaria. Something else that I want to just bring to your attention now when we're discussing urticaria is that we know already that there is a significant lack of dermatology education materials in pigmented skin. And this is particularly true in African settings and in African skin. And often the urticaria presentation in pigmented skin is actually a little bit different, and the erythema can vary quite widely. So you can see here we have a patient who would be classified as Fitzpatrick 2 to 3, and you can see that she has very well demarcated erythematous lesions. Now, these are called hives, they're also called wheals, and in Afrikaans, they're called bommels. So if you see any of these in your practice, that's what you need to be looking out for. However, in some patients with darker skin, they do not actually have the erythema, and it's often easier to feel the lesions than to see them. So it is just something you need to be aware of when you are seeing these patients. Another very important point about urticaria is that urticaria heals without scarring. If you have a patient that's presenting to you with urticaria-like lesions, that then heal in erythematous hyperpigmented areas in the shape of the urticaria, you need to have a very high suspicion for urticarial vasculitis. So that's just one very important clinical pearl to remember. So what is the difference between acute urticaria and chronic urticaria? So more than anything, it's actually a spectrum of disease. And there's an arbitrary cutoff point of 6 weeks. So acute urticaria is a patient who presents with urticaria or angioedema that's recurrent, that lasts less than 6 weeks, whereas chronic urticaria is a patient who presents with urticaria and or angioedema that lasts more than 6 weeks duration. Acute urticaria is common, and some of the most common causes of acute urticaria are exposure to allergens. Now, exposure to allergens usually has an immediate onset. And when we talk about an immediate onset in allergy, we're talking about 1 to 6 hours. So if a patient has a definite exposure history, they then develop acute urticaria with or without angioedema, you need to be concerned about an allergen. But there are also other causes of acute urticaria that people often don't interrogate on history. And one of the most common causes that we see is acute illness, most commonly a viral upper respiratory tract infection or GIT infection in adults. And in children, we most commonly see it in the context of a UTI or gastroenteritis. Finally, vaccines and drugs can also very commonly cause generalized urticarial conditions. And it's very important to ask a detailed drug exposure and vaccine exposure history. This is very important in the context of COVID vaccines, particularly the mRNA vaccines. And we found in our Sisonke cohort in South Africa that almost 27% of the Sisonke healthcare workers who had the Janssen & Janssen vaccine developed delayed urticaria. So they had urticaria that was an onset after the vaccine of about 2 to 3 weeks. And of those patients, we actually had about 14 patients subsequently went on to develop chronic urticaria. So it's always very important to remember vaccines and drugs. The most commonly implicated vaccines, as I've mentioned, are the COVID vaccines, but also the influenza vaccines. So how do we manage acute urticaria? Well, first of all, if you are concerned about a possible allergen, avoidance of that allergen is key. The next step would be to give the patient antihistamines, and you can either give standard dose antihistamines, which would be 1 to 2 tablets per day, or if the patient is really struggling and they're not responding to the standard dose antihistamines, you can go up to high dose antihistamines. And high dose antihistamines means that you're giving 4 times the upper limit of normal. And that is what we use for treatment of urticaria. The pharmacist will tell you that you're nuts by prescribing it, and patients often have difficulty filling these scripts, but that isn't the treatment course. You also need to consider, if the patient is not responding to antihistamines alone, a short course of oral prednisone. And it's important to remember to dose it correctly. Don't just give 40 milligrams of prednisone to every patient. It needs to be 0.5 milligrams per kilogram and only for 3 to 5 days. Finally, with acute urticaria, remember that if these patients are not responding to treatment and they're having ongoing symptoms, you need to start considering that this may actually be the beginning of chronic urticaria. So what is chronic urticaria? Chronic urticaria is a chronic inflammatory condition that's actually autoimmune mediated, and there's 2 types of autoimmunity. The patients either have autoallergic disease or they have autoimmune disease. In the autoallergic disease, the patients are quite literally allergic to proteins in their own skin. And that is often the easiest way to explain the condition to patients, to say you are allergic to your own skin. Whereas in autoimmune CU, what happens is the patients develop IgG antibodies, so they develop an autoimmune response to similar proteins in their own skin. Now, the name chronic urticaria can be a little bit misleading, because patients with chronic urticaria may only have urticaria, they may have urticaria with angioedema, or they may just have isolated angioedema. And this is very important because we know now in the African context that associated angioedema is more common than in the global north and in other reported countries such as Europe and North America. Angioedema is also a marker of more severe chronic urticaria because these patients are less likely to be responsive to high-dose antihistamines, and they're also less likely to respond to immunomodulator therapy and anti-IgE therapy. So there's some important points to remember. So, as we've already mentioned, chronic urticaria is common. The global prevalence ranges from 0.1 to 4.2%. and it is globally distributed. But if you have a look at all of these numbers, you can see that the global distribution varies very widely, with high rates or high prevalence rates in Mexico of 3.4% and very low rates comparatively in the USA of 0.23. So the highest countries, or the countries with the highest prevalence of urticaria that we've seen, are in Mexico, Korea, China, and also in some of the European cities. So it's globally distributed. It has a very, very high morbidity. So these patients have a terrible quality of life. And the problem with chronic urticaria is that it will not kill you, but it will make your life miserable. And these patients often have a very, very high psychiatric burden as well. And there's huge economic costs, particularly with regards to absenteeism, time off work, and job loss. So what about South Africa? And I'm quite proud to say that we have recently conducted a systematic review on chronic urticaria in Africa. And what we found is that chronic urticaria is very poorly characterized in African populations. In the systematic review, I was only able to find 8 publications that actually describe chronic urticaria populations in Africa, and the majority of those came from South Africa. And the majority of the information that we found was actually about people discussing the prevalence of chronic urticaria in dermatology clinics. And if you have a look at this image on the right, you can see that in South Africa, the prevalence in dermatology clinics is 2%, but it ranges very widely. And in some countries in Africa, including Nigeria, the prevalence rates in the dermatology clinics are up to 10%, which is 10 times higher than reported rates in Europe and North America. So this is a big problem in Africa, and we need to address it, and we need to be more cognizant of it, and we need to do more research into our own populations. Another very interesting thing, as I've mentioned, is that we seem to have much higher associated angioedema in Africa, with reported rates between 40 and 80% of patients having associated angioedema with their urticaria, whereas international rates report at approximately 30 to 35%. So as we've said, angioedema is a marker of more severe disease. So we are seeing more chronic urticaria in Africa, and we are seeing more severe chronic urticaria in Africa. Interestingly, we also found that these patients were predominantly female, as with international literature. They also predominantly had autoallergic disease rather than autoimmune disease. And risk factors that were identified for African populations include food additives, so a diet high in food additives, low vitamin D levels. And in some cases, we also found rates of chronic infection and parasites. So H. pylori being the most common chronic infection, and T. canis worm infection in Egypt actually being the driving cause. So chronic urticaria has subtypes. There are 2 subtypes. Chronic spontaneous urticaria, where the patient spontaneously develops symptoms, and inducible urticaria, which is also known as physical urticaria. And patients here will only develop symptoms on physical induction of the skin. So chronic spontaneous urticaria is far more common and prevalent than chronic inducible urticaria, with point prevalence of 0.2 to 2.7% on average internationally, and prevalence of CINDU being much lower at 0.05 to 1.5%, but those rates are still quite common or quite high. And if you think about it, we're looking at 2 to 3 people per 100 who have this condition. Interestingly enough, in both of these conditions, the age of onset is bimodal, and you have a peak in childhood, slightly younger kids in CSU and slightly older children in CINDU. And then you also have a distribution in adults, with slightly older adults presenting with chronic spontaneous urticaria, and younger adults presenting with chronic inducible urticaria. Interestingly, the remission rate at 1 year is very variable in chronic spontaneous urticaria and ranges between 10 and 80%, whereas remission rates in CINDU are much, much lower and range from 0 to 49%. And we also know that patients with CINDU are less likely to go into spontaneous remission. And something else we know about chronic urticaria is that if the patient has had onset of disease in childhood, they are actually less likely to resolve, and the disease may recur in adulthood. Another interesting point to look at the differences between chronic spontaneous urticaria and chronic inducible urticaria is that CSU is more common in females. And if you think about it, it's an autoimmune mediated disease, so it makes sense, it's more common in women. But chronic inducible urticaria is more common in men. And we still don't quite understand the differences between these two conditions and why there is a predisposition for men in chronic inducible urticaria. So the etiology of chronic spontaneous urticaria, as I've already mentioned, is autoimmune or autoallergic. And risk factors for this condition include autoimmune thyroid disease, either Hashimoto's or Graves' disease. And the triggers can be non-specific. But there's some very important points here about triggers in chronic spontaneous urticaria. The patients can have significantly worsened symptoms during stressful periods. They also can be triggered by any hormonal changes. So in women, this is very important in the context of perimenopausal and perimenstrual hormonal changes. And the comorbid illnesses can also provide a very huge burden of disease. It's important to remember as well that there's crossover between these two conditions. And a lot of patients with chronic spontaneous urticaria may also have a chronic inducible urticaria for one or two of the phenotypes that I'll discuss shortly. Chronic spontaneous urticaria patients are also more likely to have another atopic disease, most commonly asthma and eczema. They're more likely to have an autoimmune disease, particularly autoimmune thyroid disease that we've already mentioned, but also autoimmune connective tissue disease such as rheumatoid arthritis. And then the mental health disorders, I cannot emphasize this enough. Mental health disorders are incredibly prevalent in these patients. And it's kind of a chicken or egg scenario because we know that patients who have severe chronic pruritus have a terrible quality of life, and we know that their quality of life scores are actually worse than patients with end-stage coronary artery disease and patients with chronic pain. So these patients are in a terrible condition. They are itchy all the time. They can't sleep because they're itchy all the time. And even if they didn't have a mental health disorder before, they very often develop them. One of the other interesting things about a mental health disorder in chronic urticaria is that having anxiety or depression actually worsens your perception of itch. So it makes the disease seem much worse to you, and it becomes a bit of a vicious cycle. Chronic inducible urticaria is subtype specific, and I'll be going through some of the very interesting subtypes with you just now, and the triggers are also very specific. Again, these patients can have comorbid illness, and often there's overlap with chronic spontaneous urticaria. And patients with CINDU are far more likely to have atopic diseases, predominantly asthma. With regards to testing for CINDUs, each chronic inducible urticaria subtype has a unique provocation test, and I'll discuss what the provocation test means just now. So there are multiple different types of chronic inducible urticarias, and I'm going to discuss the most common ones that we see in our context. So in South Africa, we know from our data that we most commonly see delayed pressure urticaria and cold urticaria. So I'm going to go through all of these one by one and just chat to you about the differences. So the first one I'm going to comment on is cold urticaria. And the reason I've highlighted cold urticaria is that this is the one chronic urticaria that can kill patients. These patients are quite literally allergic to cold. When their skin is exposed to temperatures that are below certain rates, and each patient is an individual in terms of at what temperature they will react to, the low temperatures somehow cause mast cell degranulation. And in these patients, they can very rapidly develop anaphylaxis. So if you have a patient who has had anaphylaxis after jumping into cold water, after being caught in the rain, after eating ice cream or cold food, you need to consider cold urticaria and anaphylaxis. And it's vital that these patients are actually issued adrenaline so that they can manage anaphylaxis in case of an accidental exposure. The next type of inducible urticaria is called delayed pressure urticaria, and this is quite a fascinating one. And these patients can either present with delayed pressure urticaria or angioedema. And when you're questioning patients about this, we most commonly see patients complaining about this in the context of women having a very tight bra strap or chest strap for their bras, and then they develop hives and swellings underneath those tight clothings. And then I've included socks here because sock elastics are another very common culprit. And that's a screening test that you can do for your patient. Ask them, do they get itchy if they wear tight socks or socks with tight elastics? Or do they get hives, wheals, or any angioedema around those points? Another problematic issue for these patients is actually carrying heavy objects. So we have a number of women who, for instance, can't carry handbags because once they've had the handbag on their shoulder for a couple of minutes, they actually develop very severe swelling in that area. The next inducible urticaria we'll discuss is heat urticaria. So this is quite an interesting one, and these patients react to heat. This can be quite tricky to tease out because there is another entity called solar urticaria, where the patient's skin develops hives on exposure to sunlight. So you have to now tease out, are they reacting to the sun or are they reacting to the heat? Another type of urticaria that is heat-related is cholinergic urticaria or exercise-induced urticaria. So yes, you can actually have patients who are allergic to exercise. And the pathophysiology in cholinergic urticaria is very interesting because these patients develop hives when they have an increase in their internal body temperature. This can either be from exercise or it can be from environmental triggers. So this can be very difficult to tease out. As you can imagine, this is an incredibly, incredibly difficult condition to manage, and it can significantly impact a patient's quality of life. Finally, symptomatic dermatographism, which is another very fascinating condition where the patient's skin reacts to friction. And symptomatic dermatographism literally means symptomatic skin writing. And I'll show you an example just now of some of the hives that you see in these patients. And internationally, this is the most common CINDU type that is seen. But as I've said, in South Africa, for some reason, we don't quite understand. Cold urticaria, delayed pressure urticaria, and angioedema are our most common variants. So now we get to have a look at some really cool images. As I've already disclosed at the beginning of this talk, my patients have given permission to show these images. So if you have a look at my pointer at the images on the left-hand side of the screen, these are examples of symptomatic dermatographism. And the person that was trying to spell dermatographism here didn't spell it very well, but it's a beautiful example of what happens to these patients. So any friction that's applied to their skin then develops into wheals. And what you'll often see is, if you look at this patient below, I notice I'm not projecting particularly well, but you can see these very discrete linear hives. And this is actually an example of a patient who was using his towel to dry himself, and he dried himself a little bit too roughly, and then developed these urticarial lesions in the areas where he had used the towel on his skin. The images on the right are examples of cold urticaria. So this is the condition where patients are allergic to cold. You can have a look at this image over here. Now, this woman is a very avid hiker, and she was wearing shorts, and she got caught in Table Mountain during a rainstorm. And you can actually see a very clear demarcation where her skin was protected from the cold rain, whereas where the areas where she had exposure. And you can see that she's developed quite marked urticaria over this area where her skin was exposed to cold. This young gentleman over here is showing an example of what we call a positive ice cube test, and I'll be discussing that a little bit just now. And after applying an ice cube to his skin, you can see he developed quite a remarkable urticarial lesion in that area. The next CINDUs that are also that we've discussed briefly that I want to show you are cholinergic urticaria. Now, the reason I'm showing this image is you can see it looks a little bit different to the other hives. And what's unique about the urticaria subtype in cholinergic urticaria is that it's typically pinprick or sub 5 millimeter hives. And you can see it looks very strange. It looks almost like tiny, tiny, tiny little bumps over the skin, and it is intensely, intensely itchy. Now, this is a beautiful example of a patient that we saw in our clinic with delayed pressure angioedema. And this angioedema that you see over her shoulder area is from carrying her handbag on her way to come see us at Urticaria. Finally, there's quite a lovely image here of a patient who held his hand over his leg. And you can see in the area where he applied pressure with his hand, he developed a very well-circumscribed urticarial lesion. So chronic inducible urticaria is a fascinating condition. And unfortunately, it is very commonly delayed in terms of diagnosis. Some patients wait up to 10, 15 years before they receive a diagnosis for chronic inducible urticaria because people just are not aware of it. So it's important to be aware of these conditions. And if a patient tells you, look, I'm getting hives after jumping in the sea, or I'm getting hives after holding my phone when it vibrates, then you need to actually take it seriously and investigate a little bit further. So these are called provocation tests. So if you have a look on the left-hand side, you can see a little white box over here that's called a temp test. Now, the temp test is a specialized tool that we can use to see whether or not someone's skin is going to react at a certain temperature, and we can test for heat and cold urticaria using this test. What you do is you heat up the temp test. It's got a piezoelectric wire on it that goes from 4 degrees Celsius to 44 degrees Celsius in the shape of a U. And what you do is you place the volar surface of the patient's forearm onto the temp test. You sit it there for 5 minutes. 5 minutes later, you read it. And if you have a look at the images on the lower left, you can see a remarkable wheal on these patients. And here you can see I've outlined the wheal to make it slightly clearer in darker skin. And this patient on the left-hand side had a critical temperature threshold of 27 degrees Celsius. And what that means is that she was having urticaria and anaphylaxis to cold at temperatures lower than 27 degrees Celsius when she was having whole body immersion. And she was actually referred to us after having had anaphylaxis in the gym pool. A layman's test, or a very easy bedside test that you can do for cold urticaria, is called the ice cube test. Now, the ice cube test can be a little bit tricky because there is another condition called aquagenic urticaria, where the patients are allergic to water. So if you're going to do the ice block test, you actually need to make sure that you've got the ice block in water in a container that is dry. Because if the patient develops hives, or if you put a wet container onto their skin, are they reacting to the cold or are they reacting to the urticaria? And you can see I've given you 2 options here. So you can either put the ice cubes in a glove filled with water. Honestly, I find it easier to use a specimen bag, and they're also more easily available. With 2 to 3 ice blocks, a small amount of water. You then place that on the volar surface of the patient's arm. And what you can tell with this test is that whether or not they develop a hive to the ice, but also you can time how long it takes them before they start getting itchy, and that's called the critical threshold time. So the amount of time before they start developing hives on exposure to cold. This image over here on the right-hand side is an example of what is called a Frick test. So Frick stands for friction, and this is the test that we use to identify symptomatic dermatographism. But as you've seen from the previous images, you can actually simply write on the patient's skin and can identify patients with symptomatic dermatographism. The Frick test actually allows us to grade how severe the symptomatic dermatographism is, as well as response to treatment. So we've now finished up chronic inducible urticaria and the investigations that you do in chronic inducible urticaria to assess the subtypes. I'm now going to be looking briefly at the chronic spontaneous urticaria subtypes. This is more at the level of a physician or an allergist, so I don't expect you to know this information, but I'm explaining it now because it'll make sense later on in terms of the management, because the management of these 2 subtypes of chronic urticaria is different. So the first one is autoimmunity type 1. And here the patients develop IgE antibodies to certain components in the skin, most commonly antithyroid peroxidase, as well as anti-IL-24. So these patients have autoallergy. They are allergic to their own skin. And in terms of biomarkers, when we are using biomarkers to identify these patients in the clinic to assess what type of therapy to give them, we use total IgE as a marker, and the biomarker is a level above 43 units per mol. These patients also typically will have other atopic diseases, and they will have low inflammatory markers. Autoimmune CSU type 2B is true autoimmune disease, and these patients have IgG antibodies, either against anti-IgE or against the IgE receptor, so Fc epsilon receptor 1. And in terms of biomarkers, these patients can have raised CRP and ESR. They will have positive thyroid autoantibodies, most commonly thyroid peroxidase antibodies. And then they can also have something called a positive autologous skin serum test. So you will read about ASSTs in the literature. We don't do them often in our setting, but what an ASST is it's an autologous serum test. So you take blood from the patient, you spin it down, you remove some of the patient's serum from the blood, and you actually do a skin prick test with that serum or an intradermal test with that serum. And if it reacts, then you can show the patient that they are reacting to their own serum in their own skin. So how do these patients present in clinical practice? We've dealt with this a little bit, but before I go into a little more detail, I want everyone on the call to think about the last time they had a mosquito bite. And I want you to think about the last time you had a severe mosquito bite and it was so itchy that you couldn't sleep. And I want you to keep that severity of itch in mind. So this is a young patient who I saw a few years ago. She was a first-year university student, and she presented to me after her mid-year June exams, after a very stressful period of time. She didn't have any pre-existing mental health conditions, but she had this terrible, terrible urticaria with intermittent angioedema for more than 6 weeks. And it's a vicious cycle. She was trying to study, she was stressed, so she developed more hives. Because she was developing more hives and more itch, she wasn't sleep. Because she wasn't able to sleep, she's now become more depressed, and she's now got worse itch because of the depression. So this really is a very, very difficult cycle to break. We also see a lot of anxiety around allergy in these patients and a lot of inappropriate allergy tests being done. And that's just something I'd like to highlight as well. So these patients can be very, very challenging to manage, and it can be a frustrating condition for the patient and for the clinician. So what are our current treatment options for chronic urticaria? The first treatment option is standard dose antihistamines. And as I've already said, we're talking about antihistamines here, one or two a day. So 1 in the morning, 1 in the evening. High-dose antihistamines are 4 times the upper limit of dosing. I normally recommend cetirizine because it's cheap, it's effective, and it's got a rapid action of onset. And typically, we use high doses of antihistamines and cetirizine at 20 milligrams in the morning, 20 milligrams in the evening. There is a new antihistamine on the market in South Africa for those who can afford it, called elastine, and that is apparently one of the top antihistamines that you can use. But in my experience, most patients respond well to cetirizine. If they do not respond well to cetirizine, you can try another second-generation antihistamine such as fexofenadine, ranitidine, or loratadine. People love allergics. Now, there are multiple different types of allergics. So the routine allergics that we see is chlorpheniramine, which is a first-generation antihistamine. It's not a great antihistamine. It crosses the blood-brain barrier, and it'll cause a lot of sleepiness. The non-drowsy allergics is actually desloratadine, which you can use for these patients. But as I've said, cetirizine is cheap, it's effective, and it has the most rapid onset of action. If the patient is not responding to high-dose antihistamines, you can consider adding a leukotriene receptor antagonist. Now, you'll see in international guidelines that not all guidelines include leukotriene receptor antagonist, and this would be, for instance, one most commonly available be montelukast. And the reason being is that internationally, they have access to anti-IgE therapy and immunomodulation more easily. Whereas in low income or in settings where we don't have access to these types of medicines, we are limited in our treatment options. And leukotriene receptor antagonists are relatively cheap and they're available, and they do have some benefit in these patients. By the time your patient has reached the point where they're on high-dose antihistamines and montelukast, you really consider referring them on for additional care. And once they are referred on for additional care, they need to either receive an anti-IgE therapy like omalizumab in the patients with autoallergic chronic urticaria, or immunomodulation with a drug like cyclosporin in the context of autoimmune urticaria. So this is one of the international treatment guidelines, and this paper by Khayelitsha et al. Is a brilliant paper for anybody who wants a very thorough review on urticaria. And as you can see, it's a cyclical management, and this should be a very common image because this is very similar to other allergy managements, for instance, the GINA asthma guidelines. So step 1, assess the patient. Exclude mimics. Here, please don't forget to remember urticarial vasculitis, which leaves with scarring. You need to consider comorbidities in special populations, for instance, children and the women who are pregnant. And then you need to do a severity assessment. And to do a severity assessment in chronic urticaria, you need to use a patient-reported outcome measure. Now, patient-reported outcome measures are very, very important. They're commonly used in allergy. One of the more common ones you would have seen would be the asthma control test in the context of asthma. And this is the only way that I can actually tell whether or not my patient is responding to therapy, because chronic urticaria is so subjective. They can tell me, look, I'm itching every single day and I'm having hives every single day, but it's very difficult to tease out the severity and whether or not they're actually responding to treatment unless you have a baseline severity measure outcome. Something else you have to consider when you first see the patient is any comorbidities. So do they have concomitant CIndU and with or without CSU? Have they got a mental health disorder? I've already highlighted the importance of this in managing chronic urticaria, and it should be screened for and you should treat appropriately. Thyroid gland dysfunction is common, and so are autoimmune diseases, and you should do at least a clinical basic screen for this or refer on to further care for further testing. The next step is to act. So start treatment for chronic urticaria and treat the comorbidities. And importantly, look at non-pharmacological interventions, particularly in the patients with CIndU. So for instance, if someone has cold urticaria and you need to try and advise them to avoid cold. So if they're going to be going into a cold area, they should wear warm clothing, they should have hand warmers, they should have hot water bottles. Ideally, they need to avoid whole body immersion into water. And I don't know why, but almost every single cold urticaria patient I've had has been an avid water sportsman, and it's been very difficult to try and get these patients to stop going into the water. And then finally, patient education is really important. This condition is scary, particularly for patients who are developing angioedema, because they think that they are going to die from this angioedema. The type of angioedema that occurs in chronic urticaria is non-life-threatening. These patients will not occlude their airways, and this is something that's very important to tell patients about. Recently, when I was looking at our data, we had one patient who attended an emergency room 50 times in a year. That means almost every single week they were at the emergency room and they received adrenaline and they received hydrocortisone and Phenergan for a throat swelling that was actually non-life-threatening. So it's very, very important to educate these patients appropriately. Number 3, you then need to adjust your treatment. So go up on your antihistamines or add a different therapy. And if the patient is symptom-free for 3 to 6 months, you can step down. Very important, please, please, please tell your patients not to stop the antihistamines cold turkey. If they do, they will flare. I've added this paper here in the corner, which looks at non-skin related symptoms in chronic urticaria. Now, non-skin related symptoms include muscle pain, joint pain, malaise, and fatigue, as well as depression. And this is actually an article from our CURE registry, where as part of the CURE team, we now have almost 7,500 chronic urticaria patients on this registry. And from that registry, we've actually been able to show that these symptoms are common in chronic urticaria. Previously, they were thought to actually be markers of autoimmune disease. But these conditions are common, and it commonly happens in urticaria. You need to explain this to the patient, explain that when they're flaring, they're going to feel miserable. And it's really, really important, again, in these patients to screen for mental health issues. Let's have a look at our step-up options. And I'm just showing this as an example because you'll see that it's something that's not actually doable in our setting. So the first step is to increase the second-generation antihistamines up to 4 times a day. And then I want to highlight this box. If they have inadequate control within 2 to 4 weeks, so 2 weeks to 1 month, you need to start them on omalizumab. Now, this is almost impossible in our setting. In the state sector, government will not pay for omalizumab in chronic urticaria. In the private sector, chronic urticaria is not recognized as a prescribed minimum benefit, so medical aid won't pay either. So this means that if the patient wants omalizumab, they're going to have to pay out of pocket. Currently, the cost of omalizumab per month for 150 milligrams, which is half of the required dose in chronic urticaria, is 7,000 Rand. So to actually fully dose these patients, you're looking at 14,000 Rand a month. Now, this is a lovely way for specialists to manage these patients and to have a look at the step-up and step-down guidelines. If omalizumab fails, you can either increase the omalizumab dose, so then you're looking at maybe 21,000 Rand a month for omalizumab, or you can shorten the interval to 2 to 3 weeks. And again, the cost is huge in this case. Another option is cyclosporin. Now, most guidelines recommend cyclosporin for patients with chronic spontaneous urticaria who have the autoimmune phenotype, so high CRP, high ESR, positive antithyroid antibodies, because these patients are less likely to respond to omalizumab. Now, bizarrely enough, our access to cyclosporin in the state sector is actually much better than omalizumab, but still in the private sector, medical aid will not pay, even though these patients are significantly suffering. So how do we monitor the response? As I've already said, a patient-related outcome measure is really important. a standardized questionnaire or tool that directly captures a patient's perspective on their health status, including their quality of life, their symptoms, their functional ability, and it does not involve the clinician's interpretation of patient symptoms. These scores are vital. These scores are used to motivate for medications to medical aids. Hopefully, maybe in the future, they'll start paying for it, as well as to motivate for specialized medications in the state sector. Now, the easiest and the most common score to use is the Urticaria Activity and Severity Score over 7 days, also known as the UAS7. And it assesses two things: the presence of wheals or hives and the presence of itch. And it scores it from 0 to 3. With regards to the hives, 0 is no hives, 1 is mild, less than 20 hives per 24 hours, moderate is 20 to 50 hives per 24 hours, and severe is more than 50 hives per 24 hours. Now, each little wheal counts as a hive, and it's very important for patients because they often undercount the hives and the wheals. Itch is a more interesting one. So 0 is none, no itch. 1 is mild, so the patient has itch, but they can still carry on with their daily activities. It's not bothering them, they can sleep through the night. Moderate itch means that it is irritating them, but they can still carry on with their daily activities, even though it is bothersome. Whereas severe itch means the patient has such severe pruritus that they can't sleep and they can't actually do any of their own activities of daily living or go to work or any of their other commitments. What you do for these then is you add up the hives and the itch score for 7 days, and that gives you the weekly UAS7. Now, the UAS7 has a maximum score of 42, indicating severe disease, and a score of 16 indicates moderate disease. And this is the cutoff we use to change treatment in these patients. So if a patient has a UAS7 of less than 16, we're happy. You can carry on with the current measurement. If they have a score of 17 to 42, we need to do something about that management because this patient is struggling. So what does the patient's journey look like in South Africa at the moment? So let's say that young woman that we saw who's a university student, who's been incredibly stressed. She's now had urticaria for more than 6 weeks. She's got chronic urticaria, but it may not yet have been diagnosed. Often the first thing that patients do is they self-medicate. They take antihistamines and they consult Dr. Google. And Dr. Google will tell them that urticaria is caused by food allergies, contact allergies, by venom. And often what we see with these patients is they systematically start cutting every single type of food out of their diet. I once had a woman come to me who'd been eating bread and potatoes for 3 years straight because she was petrified that the urticaria and angioedema she was getting were related to food allergies. And this can be very, very, very difficult to reassure, to tease out. Once the patient has then gone to Dr. Google, maybe they will consult a pharmacist or a clinician. If they're lucky, they then get referred on to a higher level of care. They see another doctor. Maybe if that doctor knows about chronic urticaria, it's diagnosed. And then they're actually put onto high-dose antihistamines eventually, after this long traveling to get back here. Once they've had the high-dose antihistamines and the leukotriene receptor antagonist montelukast is added, and they're still not responding to treatment. In South Africa, our options are omalizumab, cyclosporin. Again, we've already mentioned the difficulties accessing that, or access to a clinical trial. And this is what we see in patients' journeys in South Africa. And in the data we have, we know that the median time for our patients to have a diagnosis is 9 months, with the longest time being up to 10 years. So these patients struggle with these symptoms for a very, very, very long time before someone actually picks it up and identifies the problem and starts them on treatment. So how are we doing in South Africa in terms of chronic urticaria? So this is a study that we've actually published on Monday this week, so hot off the press. And it's a collaboration between Urticaria Hospital and Tygerberg Hospital. And what we did is we looked at a retrospective folder review over 5 years between 2017 and 2023 of all patients who were coded L50, which stands for urticaria. We identified 1,153 records, and of those, 939 were confirmed patients with chronic urticaria. Our most common type of chronic urticaria, as per the international literature, was chronic spontaneous urticaria. We also had a small number of patients who had chronic inducible and chronic spontaneous urticaria. And then we had 42 patients with chronic inducible urticaria. Now, the interesting thing about these South African patients is that they were predominantly Fitzpatrick 1 to 2 skin tones, so predominantly white patients, and they were predominantly male, compared to our other two groups who were predominantly females at a slightly older age group. Patients with isolated angioedema are quite an interesting group of patients. Patients with isolated mast cell-mediated angioedema in the context of chronic urticaria account for between 5 and 10% of patients with chronic urticaria. And these patients tend to be older, they tend to be female. In our population, they tended to have a darker skin tone. And these patients also had higher rates of chronic conditions, including hypertension and gastrointestinal complaints, such as gastritis and GERD. And we know that H. pylori is a driving factor here. This group of patients also had by far the most investigations of all of these patients. And very interestingly, they were also the patients who were most likely to be allergic to food additives. So why is this study important? As you've already seen with our systematic review, there is limited information in Africa. To date, this is the largest cross-sectional African cohort that's been published. And what we found in our patients is that we had a long duration of symptoms prior to diagnosis. As I've already said, a median of 9 months with interquartile range of 3 to 15 months. And our CIndU patients had significant delays, with diagnosis being delayed up to 10 years. So imagine being itchy all the time after jumping into cold water or being exposed to cold rain and having the symptoms for 10 years before people actually realize you've got a medical condition. Unfortunately, of these almost 1,000 patients on this study, only 5 patients had access to omalizumab as a biologic, and all of these patients were from Curtis care, and we had another 7 patients on cyclosporin. So why is that important? Well, if we have a look at the number of patients who were actually receiving high-dose antihistamines in this group, only 46% of the patients were receiving high-dose antihistamines. We then look at our treatment response, and we found, we found that very, very few people were actually responding to treatment. So only 21% of our patients who had received high-dose antihistamines had had 100% response to treatment. In chronic urticaria, they define a partial response as a treatment resolution of symptoms of less than 90%, complete response more than 90%, and patients that had no response at all were sitting at about 7%. So if we have a look at our patients' urticaria activity scores over 7 days, we can see that our median was 21. Now, if you remember the cutoff of 16, this indicates that our patients had severe disease. But one of the concerning things that we picked up in the study is that very, very, very few patients were actually having patient-related outcome measures tested, with only 8% of the patients receiving a UAS7 and only 15% receiving a UCT or an urticaria control test. Now, the problem with the UAS7 is that it needs to be done before the patient sees you. It is incredibly hard to do it retrospectively. And as I say to patients, I can't remember what I had for breakfast last week, Monday, let alone how many hives I had. So it's something you need to encourage your patients to fill in prior to them coming to see you. So there is light at the end of the tunnel. There are a number of future treatments that are actually in development for chronic urticaria, including Burton's tyrosine kinase inhibitor, which results in regulation of mast cell activity. We also have serum KIT or S-KIT inhibitors, which result in regulation of mast cell survival and proliferation. And this drug is phenomenal. It's called barzolvolimab. And in patients with symptomatic dermatographism and cold urticaria, in the phase 1 trials, after 1 dose of barzolvolimab, 100% of the patients had a sustained remission for up to 16 weeks. So these new therapies are very, very, very exciting. We are also offering some of these clinical trials at the UCT Lung Institute. So if you have a patient with chronic urticaria who is really struggling, please contact us. We could possibly give them access to the treatment. And we are also offering this treatment around South Africa. There are a number of sites in South Africa that are running these trials. So please contact us. There are other options available for treatment for these patients who cannot afford omalizumab or cyclosporin. There are a number of barriers to care. And there's a recent publication that came out last year looking at a number of urticaria experts around the world and what their concerns were with difficulties in accessing management. So the important thing is the cost of therapy is not unique to Africa or low-income countries. It's a problem around the world, as well as access to therapy. Inappropriate allergy tests are also an international problem. One of the other concerns or issues with chronic urticaria is it's a subjective disease, and the importance of patient-related outcome measures cannot be overemphasized. Finally, there's a lack of awareness amongst healthcare workers, and let's be honest, very, very, very few people are aware of this condition. So we need to educate our colleagues, we need to educate ourselves, and we need to improve awareness about chronic urticaria. Finally, one of the other barriers to care that they identified in the study was actually non-adherence, with one of the authors or some of the authors estimating that only 30% of their patients were actually taking their high-dose antihistamines, and this was in a European setting. So it is a problem. We need to educate our patients about why taking the treatment is important. And then finally, I just want to show you a really, really cool invention that has been developed by the UK team called Cruise Control. And it's a free app that has specifically been developed for monitoring chronic urticaria. The patient can download the app. It's available on the iStore and on the Google Play Store. And it is a really, really helpful way to monitor patients with chronic urticaria. This is an image from that paper, and please go and have a read through. It's a really lovely way of looking at the challenges to diagnosis and treatment of chronic urticaria. So finally, in summary, I've highlighted the importance of differentiating acute versus chronic urticaria, but also being aware that that 6-week cutoff is arbitrary, and a patient with acute urticaria may actually have this beginning of chronic urticaria. The initial treatment of chronic urticaria is very, very important, particularly high-dose antihistamines. Also, the availability of treatment is poor. We know that globally this is a problem, and the treatment that is available isn't particularly good at the moment. There are limited options for antihistamine-resistant patients. So if you have a patient that's resistant, contact us. There may be other things we can do. And we actually, as a community, need to look at alternative methods here. There's been a lot of research from India looking at methotrexate use in chronic urticaria patients instead of omalizumab and cyclosporin. And this is maybe something that we need to investigate in our setting because methotrexate is cheap, it's freely available, and we have a lot of treatment experience with methotrexate and other conditions such as the autoimmune diseases and eczema. Again, the importance of patient-related outcome measures cannot be overestimated, and there are very easy ways to do it now, including the Cruise app. You need to be aware of when to ask for help and when to refer these patients for a higher level of care and possibly for clinical trial access. Then finally, we have newer agents in development. There's light at the end of the tunnel, but when will we have access to these agents, and will we actually be able to afford them when they are available? Those are the ongoing questions. So that is the end of my talk. Please let me know if anybody has any comments or any queries. We've got 6 minutes left in the seminar.
Wow, Cascia, thank you very much. I have to be rather embarrassed here as a family physician, realizing all I knew about it was that there was itchy bumps and you give them antihistamine. I do want to ask a question in terms of, because what quite often happens when we do see patients with any sort of chronic itchy thing is that they have always, either they assumed or they've already been to clinicians, is always assumed that it's definitely due to some sort of allergen. Yes. So usually by the time you've seen them, and it might have been a few months already or even a few years, as you say, they've gone through this massive exclusion diets, or they're convinced that it's in something in the soaps and they're buying various fancy products from the organic store. So it's just to know, in terms of the long-term driver of chronic urticaria, how often can it actually be either a food or a substance? And then is there any particular ways that one figure out what that is, or are we actually, that's all just a red herring that we've all been chasing?
So unfortunately, it's most commonly a red herring, and it's a problem because, let's be honest, allergy education is terrible in medical schools. I don't think I ever had any allergy talks at all, and this condition is common, but it's not, people don't know about it, people are not aware of it. I think one of my pet hates is having a patient come to me and they've gone to see someone and they've done a pediatric food test mix and a failure top and all of these really, really expensive allergy tests that are completely useless. And the patient has spent thousands and thousands of rands on these tests. It's incredibly difficult, and it's something we spend a lot of time educating our patients about. However, on the food side, there is some evidence now looking at epithelial barrier dysfunction in the gut. And there's a link with chronic H. pylori infection. So patients who have reflux and chronic H. pylori itself can be a cause of chronic urticaria. So if your patient's got gastrointestinal symptoms, they've got GERD, screen them, do a stool test if you can, and treat them. And we've actually had a number of patients who have completely gone into remission after treating the H. pylori. Another factor that can impact your gut permeability is food additives. And it was quite fascinating I didn't put it up on the slide, but in that research that we did, we found that almost 60% of the patients in our clinic who'd been tested for food additives had food additive sensitivity. And once we put them onto a preservative-free diet or a low additive diet, their symptoms dramatically improved. So that is just something to keep in the back of your head. Please don't consider doing allergy screening on everybody, because one of those tests for food additive allergy costs almost 800 Rand, and that needs to be done under the guidance of an allergist or someone who's done the allergy diploma.
That's quite helpful, because food additives are rarely essential for life, and it's actually quite often in all your harmful foods anyway. So it could be something where it might just be prudent to cut the additives out without doing the testing and see what happens. You know, it's not like you're cutting out an essential food group. I see there's some real interest here. Somebody wanting on the group, on the chat there, Cascia, if you could put an email address or even a telephone number that people can call for advice at the allergy clinic. I know there's amazing websites and things, if you wouldn't mind popping those in the chat. And then a question about courses or diplomas, or I know you're rural, yeah, so you've got some amazing website with resources. If you could talk to that.
Sure. So I'm going to put the Allergy Foundation of South Africa is an amazing, amazing resource. They are very, very active in allergy education, allergy care. It's a great site to send patients to if they are interested in learning about any allergies, as well as clinicians. And one of my favorite features is they actually have an allergy-friendly product data set. And if you're looking for allergy-friendly products, you just need to look for the AFSA seal of approval. With regards to other resources, the Cruise app that I showed has got some beautiful patient-centered resources on it discussing what chronic urticaria is. It's free. It's also available for clinicians to download, and they can use that as well. And then finally, a course or diploma. Yes, the CMSA actually runs an allergy diploma, and I can see some of my allergy colleagues are on the call tonight. And honestly, the majority of allergy care in South Africa is given by the allergy diplomats. And it's a fantastic course. It's 6 months. We offer training at Urticaria and at Red Cross and at the UC Lung Institute. And there are a number of allergists in the Eastern Cape and in KwaZulu-Natal who can also offer care and offer training. So it is a great, great, great diploma to do.
And then Cascia, sorry, I had another question as well. So just to take us back, when somebody has the induced ones, like either to the cold or to the, how long does that urticaria last then? So if they have a trigger and they've developed, like that lady who was out in the cold, do the wheels go away on their own? You talked a little bit about spontaneous resolution, or do they only go away once you treat them? And if you leave them, how long do they stick around?
So that's very variable. So the older teaching used to say that if the urticaria lasted for more than 3 days, you needed to consider urticarial vasculitis. But from the cure study that we're a part of, we actually know now that a lot of patients with chronic urticaria have urticaria that lasts anywhere from 1 hour to 3 to 4 days for a single lesion. And that is on antihistamine therapy. So the chronic inducible urticarias, it's really patient dependent, and every patient will have their own kind of timeline as to how long their hives last and how quickly they respond to antihistamines.
Thank you. I see there's a hand up. Jason, do you want to unmute and ask your question?
Hello, I just wasn't sure if I could talk on there. Can you hear me?
Yes,
Hi, Josie, we can hear you.
Cassia, thank you so much, Jason. You know me from the Eastern Cape. Phenomenal talk. Always a privilege. Always a privilege listening to you, and I always love learning. It's not really, I don't know if it's much of a question, but I always, firstly, you know, that whole preservatives and everything, you know, it's always a wonder if, because these chronic urticaria patients, they're always just hypersensitive, you know, are we getting sort of insignificant sort of sensitization, those sort of things? I'm sure they do better on the low sort of diet. but also this, I always find this, I'm saying a practical approach, and I'm asking a question is this arbitrary cutoff of six weeks, and you did mention it earlier, because sometimes when you practice allergies enough, you anticipate, like, okay, cool, we know this patient's probably going to end up with a CSU. Do you always, like, in your practice, is there times where you start earlier, where you go, okay, cool, I'm not going to wait for the 6-week mark, I know where this is going, because I know this whole arbitrary cutoff, wherever it came from. So I just thought, what's your practical view? I know when we get the acute virals and that, but sometimes, this patient, if you understand what I'm saying. But thank you so much. What a phenomenal talk again.
Thanks, Jace. So I think you'll probably actually have more experience than me with the acute urticarias, because usually by the time they get to see me, they've had urticaria for quite a while. I've only really had about 2 or 3 patients with acute urticaria that I personally looked after that then became chronic urticaria. But usually if they've had symptoms for, this is my personal experience, there's no evidence for this, but if a patient's had symptoms for at least 2 weeks, then it's pretty convincing that you're on the road to CSU or to CU. And I often counsel these patients and I say to them, look, this might be acute urticaria, but if the symptoms continue for a longer period of time, then we need to start looking at other causes. And just so they're aware, because the testing can be quite intense as well.
Thank you very much. I'm not seeing any other questions or hands. But yeah, lots of feedback in terms of, let me just run the poll. Or have she done me a poll? Let's just try. Yeah, so please fill in the poll. We need that for HPCSA reasons. Otherwise, I would like to really say thank you, Cascia. We're definitely going to invite you back, because I think, yeah, you say allergies is just not well covered, and maybe specifically looking at like food allergies and your typical, those kinds of things, to actually really go into depth with people who are presenting with allergies. Yeah, we haven't had a talk on that either, so that would be very helpful. And it's interesting, it's one of those things that's being looked after in very specialist clinics, but it's actually a condition that's mostly seen and looked after in primary health care. I don't even think most GPs would consider referring somebody with urticaria, and if they did, they wouldn't know where to send them. So I think building that awareness and skills within primary health and then creating proper referral pathways, I think we can definitely look at how we get the message out to our rural facilities. And I'm going to start with...
Sorry for interrupting, but on that note, I realized I forgot to mention that we are more than happy to help out if people have any questions or queries or difficult patients. You can contact us via the Vula app, or you can contact us via my email, and I'm more than happy to point you in the right direction or recommend someone in your area who might be able to help.
That's very helpful to know that you're on Vula. That's excellent. Yeah, I think we'll use you through that route. That's amazing. Thank you very much, everybody. Yes, we're very nicely on time. Thanks again, Cascia. Have a lovely evening. I'm going to stay on the call for a couple of minutes so people can finish with the poll, and then we will let you know about the next webinar, which will be in May, and we'll be sending out the programs for the monthly ramp meetings. Thank you very much.